Hi, everyone. Thank you for joining us. My name is Shiv, Gaglani. I'm the co-founder and CEO of Osmosis, which is now Osmosis from Elsevier, because 6 months ago when we presented here, we were an independent company, but we just joined Elsevier a couple months ago. We have a really great panel today, and when they start speaking, they're going to introduce themselves really quickly. We're talking about how to evolve healthcare pathways to meet the critical need for healthcare providers. In the last 6 months, I think last time we were on this panel, we were all wearing masks, and now it feels like a totally different pre-pandemic level. It's really good to see all of you without masks. However, not everything has gotten better. Years ago, even before we knew what COVID was, or all of us knew what a coronavirus was, we had a shortage of healthcare professionals, with the Association of American Medical Colleges predicting a shortage of 134,000 physicians by 2034. 2 years into the pandemic, it's gotten even worse. More clinicians have burned out, and just earlier this month, there was a Forbes article based on this report by Elsevier called Clinicians of the Future, where they surveyed 8,000 clinicians across 150 countries, and there are a lot of amazing stats that came out of this, and scary stats, including that 1 in 3 clinicians are considering leaving their current role by 2024, with as much as half of this group in some countries leaving healthcare for good. And so the panel is going to talk today about how we can meet these needs, and from physician assistants and pharmacists all the way to healthcare administrators. So the first question I'm going to pose to the panel is, with all this burnout and turnover, what are some of the factors behind this, and how can we start addressing them? And anyone can start.
I'll jump in. I'm Beth Phillips from ATI, and I think there's a lot of factors. I'm in the nursing focus, and nurses historically have been the catch-all for so much of the workforce, so much of the healthcare setting, and they're tired, they are exhausted, and the workforce continues to demand more and more of them. And so I think that that is a huge part of why the burnout is happening. They're seeing that they could still be a nurse, do something different somewhere else, maybe even get paid more and work better hours as well.
Hi, I'm Katie. I'm from Emeritus, also a nurse by trade, and couldn't agree more. We've really doubled down on practices that just don't work with nursing, and have been historically tied to practices that really don't make sense. One example I'll throw out is the 12-hour nursing shift. We started this in the 1970s, and healthcare has changed dramatically since then. Yet we're still locked on this practice, even though we know that nurses that are working 12-hour shifts report dissatisfaction with their job at a rate of 40%, and have an intention to leave their role within the next year at a rate of 30%. And then we act surprised when we do the same practices, yet the turnover is at this astronomical rate that it is. Just to even further elaborate on some of those numbers, I pulled up a recent survey. Only 200 nurses were surveyed, so very small sample size, but 90% of them in this 200 group said they intended to leave their role within a year. And 71% of those nurses had over 15 years of experience. So what this says to me is, not only do we have to obviously double down on the pipeline for nurses going into the profession, we have to really, really invest in the nurses in the workforce today. And this means from a financial aspect, as well as a comprehensive investing in the person as a whole, to make the workplace setting better and more attractive for nurses.
I can kind of add on to that. So I come from a little bit of a different, my name is Kathy Hunter. I'm with the National Health Career Association. We're a professional credentialing association for entry-level healthcare professions. So things like medical assisting and pharmacy technicians. And Mercer just came out with a report that we're going to have a shortage of over 3.2 million entry-level healthcare workers in the next 5 years due to the high turnover we're seeing in the industry, plus the low enrollments that we're seeing come through schools. And I think there's a lot of reasons for that. I think the pandemic, these are high turnover professions anyway, and I think the pandemic even exacerbated that, because they were trying to do more and more and more, and still try to keep their family lives in order, still try to keep their personal life's on track with the requirements of the job getting steeper and steeper. And then I also think that we're starting to see wages increase in other industries. And so for these lower wage healthcare professionals, which are critical to the operation of the healthcare setting, they're seeing other industries pay $4 and $5 more per hour, and they're leaving the industry. So it really is a crisis.
Hi, thanks. I'm Derek Apanovitch, Chief Operating Officer for Osmosis. I just would want to add a few points. Many people in the room during the pandemic probably had a somewhat easier lifestyle, working from home, being in front of Zoom. You had more flexibility in your day, but for clinicians, it was exactly the opposite. They were working under siege conditions. In some cases, they were furloughed at the beginning of the pandemic. And then there were nursing shortages, clinician shortages during the pandemic. So I think many of our clinicians are still getting over that right now. And I think it's hard for non-clinicians to realize how traumatic that could have been. And then just one point on the wage front, many of those jobs at the entry level of healthcare, like you said, don't pay that much. And a lot of the wage competition right now is from jobs that require very little or no training, when you could be getting paid actually more without going to school, learning complex healthcare concepts, and in some cases going into debt for that education. So it's very hard to compete with the wage market the way it is right now at the entry level, unless we pay more and get better at showing career pathways.
These are all really good points. And so let's focus on practicing professionals first, and we'll get into the training of new professionals, because it doesn't make sense to keep filling in a leaky bucket, as they say, and the bucket's very leaky right now. So going on your point about 12-hour shifts being sort of antiquated, what are some of the other structural things that are happening in the healthcare system that you think we should be trying to fix and changing, including on-the-job training? I know we were talking about that earlier before the panel, or travel nursing and how exorbitant that is. So feel free to start, sharing some of that.
Yeah, so one thing that I think we do with our nursing curriculum that needs an update is we really focus on the primary nursing care delivery model, which is great, and there's a lot of benefits to that, but we don't have the staffing models to support that. So nurses inherently aren't trained to be team leaders, yet they're working as team leaders with their support group, with LPNs and other RNs that they're training really early in their careers. 1 year on, you're already precepting another nurse. So healthcare systems really need to train their nursing colleagues to be leaders and effective communicators. And I think if you can upskill our staff and teams to do this effectively, they'll be set up for better success when they're working with the staffing models that we have to work with, because we don't have the pipeline in place and the support structure in place to retain our nursing colleagues.
I agree with you, Katie. I think the other thing is the actual setting has to change. We have a whole new generation of clinicians that do not think that work is their life, like some older generations did. And so to have some job sharing opportunities, to get rid of some of these 12-hour shifts, these long stretches of days, so that there's some quality in what they do. And then the appreciation and the acknowledgement of a job well done, I think, has been really lacking. And unfortunately, it's not just at the base level, it's administration as well. So I think we have to fix all those levels.
Yeah, one area I would just add is, and we talked about this ahead of the conversation today during our prep, is how nurses are compensated. At hospitals, it's largely based on room charges. And so it's really a cost for healthcare systems, and there's often an incentive to try to drive down that cost by having fewer nurses on staff. We do know that lower staffing ratios, and there's been a lot of studies on this, can cause patient outcomes that are not as good if the staffing levels are higher. So I think that's something that we could look at more as a society in terms of where our dollars are going. We know that we're continuing to spend more and more on pharmaceuticals and medical device products. It's about 20% of overall healthcare expenditures right now, and that rate of increase is going up much more quickly than what we were paying for nursing care in acute care settings.
And then I would just finish with, For these entry-level healthcare professionals, they just need to understand that there's actually a career path for them. We need to be able to retain these workers. We pay to train them up. We put them in a job, and it's not a career, it's just a job. And so there's not a lot of incentives to stay. So, you know, at a time when talent acquisition and retention is more important than it's ever been before, how do we bring an upskilling pathway to them and actually have it be a directed pathway that would allow them to see a future for them in healthcare?
I want to weigh in one more point, too, about the compensation. So obviously, we need to rethink compensation for our healthcare colleagues. I think that this has really been evident with the pandemic and the travel nursing industry. But if you look at the healthcare systems that did well with retention or better than other organizations, it's because they created a culture where their colleagues felt respected and cared for. So it wasn't always about the dollar amount. I think the dollar amount is important, but it's also having that top-down leadership approach where they're really valuing those frontline caregivers and really just doing those small things that you can to make their lives a little bit easier, like shared staffing models, or even just better cafeteria options, dinners to go. Small things like that actually make a bigger difference than people think about.
So those are some really positive kind of changes. There have also been some examples that, we talked about Vanderbilt, which somebody can describe what happened there, that have been the reverse. So it's, you know, I think every one of us work in an organization that are facing things like the Great Resignation, the hidden resignation. That's just compounded in healthcare. And so some of it is what the panel's been saying about improving benefits, and maybe we can talk about on the job training as well would be a good thing to start weighing in on. But then also reducing the negative parts of being a provider in a hospital. So if somebody wants to approach what happened in Vanderbilt to fill in the audience, I think that would be a really interesting discussion about why we think so many nurses and others, health professionals, may be leaving the profession.
I mean, in a nutshell, it was a medication error that a nurse committed, and there were several system errors across the board that happened, but the nurse was charged and actually was charged with homicide. And the rest of it was kind of hidden. And I'm not picking on Vanderbilt. I think these things, unfortunately, happen more than we know. Med errors are a real part of anything that a human is touching. So the nurse followed the protocol once the mistake was made, but it kind of was a scaffolded error that just fell and fell on her. And I think that put a lot of fear in nurses that do this every day, with more and more expectations, less time, less assistance. And so the system has to change. It's not an individual error, it's a system error.
Yeah, I mean, we've done so much work since the IOM report to err is human, but still have gone backwards in patient safety and deaths related to patient safety events. So I just worry that our work in just culture and having people step up or raise their hand when they see that we have these systematic process errors and they could potentially lead to a situation like what we saw in Vanderbilt will stop. And that is really even more scary to think about. So, you know, that also just goes back to healthcare systems really need to show that they care for their employees and that they support their employees to speak up when they see these types of things in place.
I think you're seeing the same thing in pharmacy. So the rate of change in medications, the rate of expectations of on the job, the rate of regulation change, it's really, really hard to keep up. And there's very little time for training in a world that there needs to be a lot of training in order to prevent medication errors.
Yeah, and I would just echo the importance of employee retention. If you're at a hospital, you're getting used to systems, processes. If you're not retaining your employees, and many of us have hired employees, built businesses, if you're constantly churning your employees, it's very hard to be successful and maintain good patient satisfaction scores and good outcomes. And Katie mentioned the traveling nurse phenomenon. Almost by definition, they're going hospital to hospital, and they're not going to have that same understanding of the processes and the systems at each hospital in many cases, and that introduces more risk. In addition to just having the nurses on staff work right next to somebody doing exactly the same job, in many cases getting paid 3 times as much and not being part of the community and the culture at the hospital. And some of this may have been necessary during the pandemic to fill acute staffing needs as COVID cases spiked in various parts of the country. So it made sense, but it seems like a lot of healthcare systems are relying on these short-term staffing solutions more as a normal practice now. So it'll be interesting to see how that plays out over time, both in terms of costs and employee retention and engagement.
Well, and I don't blame the traveling nurses. I mean, they're looking for a way to get a little bit of life quality, and they're making a lot more money, and they see it as a short term. It used to be a 13-week rotation was the shortest time, and they've now decreased it to 6 weeks. I can't imagine getting comfortable in a role in 6 weeks in a brand new state, brand new hospital, and all of that. So, and then they aren't part of the team really. So I think it really builds, and I don't think it will last. But we always have these little knee-jerk reactions to trying to fix things instead of looking for long-term solutions, I think.
Yeah, no, those are definitely some difficult challenges we all have to overcome that are systemic, not just about training. But let's go into training a bit now too. So many of us are familiar with the companies, many unicorn edtech companies like Guild, Degreed, Pluralsight, that all have very successfully done on-the-job training, right? So Microsoft or some company will purchase one of these products, or Walmart with Guild as an example, and provide opportunities for people to upskill, which is good for, as a benefit, good for retention, but also makes the labor workforce much better. We haven't seen the consolidated player like one of those in healthcare. There have been a couple, there's been a lot of fragmentation. Can you guys talk about some of those pathways for on-the-job training and what maybe some health systems are doing right, or what companies are emerging that could be doing this, that in a couple of years it will be like the degree of healthcare?
I can jump in on that. I think one of the first things that you can look at how you're upskilling and reskilling nursing staff is, from my perspective, look at your frontline managers. So when I was a brand new nurse manager, I walked into the office, was handed a $1.2 million budget and told good luck. So there was a lot of opportunity for training, not just from a leadership perspective, but from a financial acumen perspective as well too. I also think from an upskilling and reskilling perspective, what a lot of healthcare systems are doing is they latch onto that standard tuition reimbursement model. So if we can move away from that and allow people to have different opportunities for other types of educational interests, I think you're more likely to retain those individuals in different spaces, even within your healthcare system. One example would be the telehealth, telemedicine space. So if you have a nurse that's been around for 15, 20 years, they're really interested in working more in the telemedicine virtual world, why not provide reimbursement for an educational opportunity for that?
Yeah, I think the other solution, I think we have to look at the preparation for nurse educators or healthcare educators totally. Historically, if you're a great clinician, let's bring them into school and let them teach. And that's not the same thing. They need to be prepared to be an educator. And so professional development for that group has to happen. And we can't anymore rely on the schools that are already overstressed. There's a huge aging out of nurse faculty in our country. I think the average age is 57 now. And so some of that departure we're going to see big time in the schools, and who's going to be left to prepare them? So I think there's a real opportunity to really beef up our professional education for clinicians to educators.
I think one of the things that we've heard from our professionals and our employers is that they have these upskilling systems, but they're somewhat fragmented, and it's really hard to piece together all the components that you need to actually have career advancement. And so some of the things that some of our advisory board members have started to do is actually create directed career paths for some of these entry-level workers and actually put the learning together and actually use it as an acquisition strategy. So they're using it to say, hey, come work with us and we'll show you a path of advancement. And they actually, have directed learning that you do throughout your pathway to continue to advance. Another really interesting thing that we've seen is employers are starting to work for entry-level healthcare professions with high school CTE programs. And so we're seeing more and more adoption of employers saying, hey, will give you the facilities you need as a junior and senior in a CTE program, train you to be a phlebotomist or a medical assistant or a farm tech. You can work. Most of those kids do end up going to college, but they're working in the healthcare system as an MA or as a farm tech while they're pursuing their education. And so they can earn while they learn, which is seems to be a really attractive model.
Yeah, one other thing that I think would be good is, like Katie said, moving away from just focusing on degrees and focusing more on very practical training to help clinicians be more effective on their jobs. So I think some of the more progressive institutions, medical schools, nursing schools are using what are called virtual panels with their EMR systems to try to simulate what it's like to manage a caseload, to get different examples of conditions, to suggest a course of action and get feedback. More in that virtual setting, using the technology in an effective way. It seems like technology doesn't always lead to better outcomes and job satisfaction, as we're seeing, but that could be one way where the technology is actually used in a very productive way. And you can weave in themes like patient education in those virtual panels, so you can communicate more effectively with your patients. We do know that the source of job satisfaction for most clinicians is positive relationships, meaningful relationships with their patients, and not just going through a series of transactions and processes. So.
Yeah, I agree with that. And I think the use of simulation in virtual environments is not everything. It can't be the entire education, but it can definitely introduce them, strengthen their experiences, help them learn those communication skills, team leading with examples, and then get them into a clinical environment with real people so that they can strengthen those skills as well.
So why is it so fragmented? Like why is there no one-size-fits-all curriculum for all medical assistants or all nursing professionals in a hospital right now?
I mean, part of it is we have boards of nursing in every state, and they have their own guidelines, their own rules. We have at least 3 accrediting bodies for schools that go for accreditation that have their own guidelines. So there isn't a one path. And then in nursing, we have LPNs, associate degree, diploma, BSN, RN to BSN, master's entry. I mean, the list goes on.
And so this is one of the systemic structural problems of why a company in healthcare education has trouble reaching that scale,
Yep.
right? Because if you're teaching somebody Node.js or Python, that's the same everywhere, right? Versus maybe a company trying to do, phlebotomist training that depends on the state, right?
It does, and I do think that's why we're struggling with scalable models, because everyone does it differently, and every state does it differently, and every employer wants it done a little bit differently, and it's hard to even kind of get to what's the 80%. Can you even get to the 80% that's common, and then maybe have customization for the last 20%?
And so, anything else on that topic? Otherwise, I'll switch gears to training.
No, I mean, I think we could be here all day talking about the pain points of the Board of Nursing. I'm just trying to be mindful of time.
Yeah, 16 minutes. So let's go a little further upstream. So the actual training, you mentioned the very innovative kind of vocational training programs where an employer will set up pathways for high school students to start earning money while they're continuing to invest in their healthcare careers, hopefully. We know that there's a shortage of schools. We know that there's a retiring nurse faculty population right now. What are some of the things that we could be doing, apart from building new schools or increasing enrollments, to make the training of the next generation of healthcare providers more effective? There's also some stats one of you mentioned about how a graduating nurse is more likely to leave the profession within a couple of years. So I don't remember exactly what that is, but if you guys want to dive into the upstream training, it could be a good time.
Yeah, maybe just to get the conversation going. So if you don't build new facilities, you can also use the facilities that you have, right, more effectively. We know there's many medical schools in the country that are trying 3-year programs instead of the 4-year program. For about 100 years, medical school has been 4 years, right? 2 years of foundational sciences, 2 years of more clinical focused work, and many medical schools like NYU are trying to do that in 3. It's a very structured, rigorous program, but I think there's increasing acceptance of that. So if you get students through a 3-year program, as the years go by, you'll have more and more doctors because the program is shorter. You also have less student debt, which is very important if you're going into the field. Less student debt in any of these disciplines can result in a wider range of choices in terms of what you end up doing after medical school or nursing school. It may allow you to work in a medical profession like family medicine that pays less than cardiology, for instance. So I think that's extremely important. So really focusing on the curriculum, what's essential to become a strong practicing doctor or nurse. I think we can gain a lot from that exercise and just doing that very rigorously. There's all sorts of other statistics. 80,000 nursing applicants who are deemed qualified don't have a spot each year. To me, that doesn't make much sense given all the other issues we're talking about today, that we can't figure out how to give spots to those deserving candidates.
I think a solution is competency-based education. I think we're moving in that direction, but why have someone sit through all the same coursework if they've already completed it for another degree, or like an RN to BSN program, for example, they've already been working as an RN, so why can't they own some of that experience and demonstrate their competency and then move on to the next thing? I think it would increase their satisfaction. They'd probably stick around longer, and we'd have more clinicians.
Yeah, I just want to comment a little bit about how we have these qualified applicants for nursing schools, and yet we don't have the capacity to educate them and get them ready for practice. One of the problems is the nursing faculty shortage. So we have all these community colleges that are really struggling to get access to high quality faculty. So that's where I think healthcare systems have the opportunity and also the responsibility to partner with educational institutions, whether it's a university or another educational provider, to train their nurses to be high quality educators, to prepare people for the practice that is the profession of nursing as it is today, not necessarily how our curriculums are preparing them to do that. But then there's other limitations for getting nurses to nursing school or through nursing school as well. California Board of Nursing is one that caps enrollment on nursing schools. So we have buckets and buckets of qualified applicants, but cannot go to nursing school, not because there's not the faculty, not because there's not the clinical capacity, but because the California Board of Nursing says X amount of enrollments are allowed at X school. So that's another challenge that we have to think through. And then the other piece is curriculum. And does it have to be that historical, like we talked about with med school, 4-year curriculum, or is there different, more creative ways that we can make the learning more accessible to the students remotely, but also providing that the right appropriate amount of clinical environment experience?
And just to kind of build a little bit on the competency, I think that it's really, really important for the competencies to result in an outcome, and an outcome is employability and its success on the job. So I think it has to be tightly collaborated with employers to make sure we are training the right skills. And then when we're thinking about skills, I would just say that doesn't just mean the clinical skills, but it also means the social skills, the interpersonal skills, the critical thinking skills, which I think sometimes are the first to go when we have a skills-based program.
Speaking on that topic, what are some other kind of like, if you were a dean of a nursing school or a med school, or again, you have been nurse managers, for example, what skills, so we said soft skills, but like to paint the picture for the audience, what are like some very specific things you think we should be training and changing the curriculum for right now, for the clinician of the future, as opposed to the clinicians that we've been training for the past 100 years?
I just can't, they're not soft. There's nothing soft about them. They're really dynamic skills. And they're the things that you might not be able to see. You can see me put an IV in, but can you see the way I talked to the client and included their family and explained what I was doing? So I think those are really some of those skills, that therapeutic communication and kind of reading the room, understanding nonverbals as well.
Shared decision making.
Exactly.
Agree, and commented on it earlier too about leading teams. And I also think we need to really prepare our leaders, nurse leaders, physician leaders to really be change agents in polarized environments or chaotic environments, because that's what I would call healthcare right now, is a little bit chaotic. So we have to kind of figure out how we can make some big dynamic changes to the system as a whole. And I don't think general nursing programs or even med school prepares people to do that.
I might just add, I think that we see struggles with professionals who don't really understand an overview of the business of healthcare, so they don't understand how their actions actually impact the operations of a healthcare environment. And I think there needs to be, obviously not really deep training, but training enough that they understand what they do and how it impacts. And then we see a lot of professionals struggling with technology. Technology is changing, very, very rapidly, and it's not always a core piece of these clinicians' jobs. So how do we make technology easier for them and train on it?
Yeah, just briefly agree with all this that's been said. I think basic business skills are important, some data science skills, some process skills, how to discharge a patient, how to manage a caseload, how to manage a team, how to motivate a team, how to communicate with a team, how to engage a team. A lot of doctors, nurse practitioners, physician assistants, nurses are effectively managing teams, multidisciplinary teams in a healthcare setting. And that doesn't come naturally for everybody. I think there are ways you can train to become a better manager. It's not going to work for every clinician, but at least give them the foundation to be able to give it a shot. And if you're a member of a team who's managed by a quality, motivated, dedicated manager, chances are you'll be happier. We know the research suggests that if you're an employee. So.
That's a good point. I'm glad you mentioned that, because we talk about healthcare providers, we talk about entry-level healthcare providers, we talk about nurses and doctors, but there's also the managers who may not be clinical, right? Masters of Health Administration, CEOs, chief risk officers at these health systems. Is there like a curriculum for them? Like, is there training enough for them to apply best practices across health systems?
I think this is a big opportunity for even organizations like Emeritus to get into that space, because it is really important for me when you have these senior level healthcare leaders, not only to just educate them and provide them that educational experience, but to connect them in a room together. So a lot of healthcare systems have training that is homegrown, so you're learning from the same leaders within your institution and don't get to hear what's happening at your neighbor hospital or a hospital across the country that may be this great best practice that just hasn't caught on yet. So I think cohorting groups like the chief medical officers, chief nurse execs, and having them work together to come up with, hey, let's figure out how we can do a totally different staffing plan that breaks even or is close to the cost of what we're working with now. Have those leaders that are industry experts troubleshoot it together. So I see learning from your peers as just important as the learning content in general.
And that would be a force multiplier, because a lot of, I think, what we focus on is how do we get the front lines to be more resilient or to be happier and healthier and things like that, whereas the system is broken. The 12-hour shifts, the fact that you have travel nurses coming in, which makes sense from an individual perspective, but as you guys have mentioned, can be very demotivating to work with someone who's just going to be gone in 6 weeks and is making 3 times more than you per hour. So I think that is a really interesting opportunity for how we could train not just focus on the front lines and the managers, but the actual CEOs of health systems to be better.
Yeah, one point just to keep in mind, a lot of regional nonprofits, for instance, healthcare systems could be $3, $4, $5, $6 billion businesses. There could be units within those systems that are $300 million, $500 million. So if you think of all the focus we place on quality management and MBAs and training for the for-profit world, the business world, we may need some of that same focus in these settings where there's been such a consolidation of healthcare services, and that may have been happening kind of before our eyes, and then all of a sudden we have these people with enormous roles and influence and power over thousands of employees, in some cases, hundreds of thousands of lives in the community. It's daunting. And if they don't have the right training, the right outlook, or if it can be improved, you can see the positive impact that could have, in the community. So.
So we're coming up on time. We have about 6 minutes left, and I wanted to make sure we go through give each of you one final word on this question, which is, if you had a magic wand and you could just prioritize one thing to change about how we train or retain healthcare professionals and the healthcare workforce, what would it be and why?
I think for me it would be to change the narrative around the nursing profession as it stands right today. So if you Google nursing profession, what's going to come up is burnout, fatigue, turnover. It's not necessarily an enticing profession for people to be interested in exploring. So I think healthcare systems need to double down on their biggest asset, which is their nursing professional colleagues, and show them that they're cared for, respected, not just financially, but from a comprehensive approach. And that includes educational opportunities, that includes anything that makes their lives a little bit easier, a little bit better of a day-to-day.
I would say if I had to do one thing, it would be to really strengthen our professional development, because if we don't do that, it doesn't matter. They're going to go into an environment they won't have the resources. So in all of our healthcare professions, I think we need to really look at our curriculum, update it. These are very old traditional curricula in many cases, and make sure that the educators are prepared for the future, not the way it's always been.
Yeah. Just kind of building on that, I think that if I could do one thing, especially for entry-level professionals that have so much impact on a healthcare setting, I would really rethink the learning journey. How do we provide more on-ramps and off-ramps to education that are affordable and accessible to entry-level healthcare professions? And I think that involves some unique ways like the high school path or the apprenticeship paths that we're getting. But then once we get them into the workforce, how do we continue to develop them so that we can keep their skills in the workforce and continue to use them to do more important things as they progress in their career?
I would shorten the healthcare programs as much as possible to keep the debt down and to keep the focus on what's most important for the jobs the graduates of the programs are likely to get in practice. I think a lot of what's being taught today is not very relevant, and that's probably true in a lot of educational programs for when you get to the job, what it's actually like to be a clinician. What are you doing on a day-to-day basis? There's a lot, of course, you need to know as a healthcare provider, a lot of factual information, but it seems like a lot of that factual information is easier to access today through all sorts of different tools, protocols, decision trees. There's all sorts of resources you could have to access that information once you have a basic understanding of the sciences. But to actually be an effective, happy practitioner, it seems like that's much harder for us to achieve these days, and trying to understand why that is. Are we not training on the right things to get somebody comfortable in the settings that they're going to be in? So I'd want to figure that out.
I think this is a positive note to end on, because when we were prepping for this panel, there's a lot to be scared about and anxious about. And we were joking about maybe giving everyone here a free Headspace membership for a year, just given how depressing this can be. But I think the solutions are there, and people like the panelists are working on them. And we invite you to, if you have questions, come find them afterwards, have conversations outside, or get in touch. And this may be the first panel in ASU+GSV history that ends 2 minutes early. So we'll give you back 2 minutes of your time before the music plays or Will Smith walks on the stage and punches me out. So have a good rest of your day. Thanks for coming.